Welcome back. I'm Kimberly Madison, a doctorally prepared nurse practitioner and one of your co-hosts here at the Melanin Initiative podcast. I'm back with one topic at a time. Today, that topic is pap smears. We did receive a question from our audience about this, but we're also going to touch on cervical cancer and HPV, or the human papillomavirus, because they're all connected. So I think this is a great topic for some slides. And I think this might be my first time doing them for the one topic at a time. But if you've seen the show, then you know that we've been using them. I don't want you to get a sneak peek of what I have. Okay. So we're talking about pap smears. And so pap smears are an exam that we perform to check for a risk for cervical cancer in anyone who has female reproductive organs. So even if you identify as a transgender male, but you haven't had any gender affirming procedures or surgeries to alter or change your organs, then this still can apply to you. And so it's very important to disclose that information to your healthcare providers. So real quick before we get started, in addition to answering your questions, improving your health literacy, and talking about these different topics, we're also promoting credible resources. So the internet is a wonderful place. It's a beautiful canvas for anyone to upload and share their stories, their journey, and any information as they choose. But that doesn't always mean that it's a credible resource. And so it's really important, particularly when we're talking about healthcare, that we use resources that are credible. And when I say credible, I'm thinking things that are related to evidence. All of our practice is based on the evidence. Healthcare, medicine, it is a science. And, a lot of times patients, particularly Black patients, because of our history, when it comes to being experimented on, can often feel like they're being a guinea pig, or that we're testing on them or experimenting on them. And, before we bring treatments to the public, there is research that goes on, and research is science. It's evidence-based, it's guided using strategies that have been proven. There are protocols in place to protect people's identity, confidentiality, as well as their safety. Anytime we conduct human research or human trials, there's a lot that has to be go into account, and a lot of approvals that have to take place so that we don't have any of those repeat occurrences from the past. And so what I think is really important for, Black and brown communities in particular is, because we have that history and there's a lack of trust in the community, I think it's really, really important to be transparent, to share where we're getting our resources from, where you can go and look at the same information and, read for yourself, make your own evaluation on whether you think that information applies to you and whether you think the information is sound. So I try to do a pretty good job of providing where I get the resources from so that you can go there. And in the description box, I'll include those links. So this image comes from the National Cancer Institute, or NIH, National Institutes of Health. They have a wonderful reputation for research, incredible resources, and so maybe you're familiar with them. So here we have the female reproductive system. Today we're going to focus on the cervix, which you know what I need? I need to figure out some software that allows me to manipulate the mouse on the screen for you all. So if you have any recommendations, send them my way. Otherwise, I'll keep looking around until I find something. So right there, if you can see where it says cervix, that's what we're going to focus in on. So these are all your internal organs. On the outside, you see the vagina, which is what most people are familiar with. And as you can see, that vagina is like a passageway from the outside of the body to the inside of the body. And so when we take a closer look, as soon as the patient gets on the bench, they're going to wear a gown. They're going to get on a bench that has stirrups or places for them to put their feet, which we'll see shortly. We'll have them separate their knees. And the first thing that we're going to see is this beautiful, healthy cervix. This is a healthy cervix, what a healthy cervix looks like. So right there on the screen, you see where it says cervix. What we're doing is we're going to zoom in. And right there where it says external os, OS, That's what we're seeing. So as soon as the female separates their legs, and it allows us to see the uh, vaginal entrance very easily, we'll put in the stirrups, and that will just help us to open it up so that we can see directly, and that so we can do what we need to do in there. So the first thing you're going to see is that external os kind of looks like a donut without a really big hole. And like I said, that's what a healthy cervix looks like. Over on the other side, where it says endocervix and ectocervix, are some cells in an area called the squamocolumnar junction, or also the transformation zone. And that's where most cervical cancers are found. And so, you see this space, it's quite small. Just like other parts of the body, whatever is there is what's meant to be there. And so whenever we have cancer or some sort of a mass or cyst or infection, something that's not supposed to be there, that now is going to take up space, we're going to start to see some complications with that. One of the first things people might feel is like discomfort or pain. But if you can imagine, if we're catching it very, very early, you might not feel anything because there is a little bit of wiggle room in there in terms of space. But once something gets large enough for you to feel it, large enough for us to feel it and to see it, we know we have something pretty advanced. And so that's why it's so important. Screening, or what's considered early detection, is always being emphasized, because if we can catch it when it's very early, when you don't even have any symptoms, we don't want to wait till we have symptoms to get treated. Then we have so many more options available to treat it. And some things, maybe it's not a cure, but it can definitely help. And in other cases, it is a cure. Okay, so again, we're talking about cervical cancer, which is in the cervix in the female reproductive system. And right there where you see that donut-shaped structure, that's your cervix. And on the other side are those cells, and that's where we typically see cancer appearing. So keep that in mind. So let's talk about some symptoms. I did talk about pain, and that might happen later in the disease process. It just depends. So let's just take a look. So in the very, very beginning, you might not have any symptoms at all. When you get your pap smear, that might be the first time that we even see something concerning. But you also might have vaginal bleeding after sex, vaginal bleeding after you've been in menopause for a while. That would always be concerning. You might have heavier periods during your period or in between, or a lot of spotting more than usual. That's why it's really important to, just pay attention to your body, the regularity of your menstrual cycle. You can certainly keep track of it on your calendar on your phone. That's what I do. There's a cute little icon and the cute little emoji that I like to use to track my menstrual cycles. No one else would even know that's what it is, but that's one way that I do it. And then you might have pelvic pain or pain during sex. So, if you're new to sex, or you are the activity that you're doing is likely to induce a lot of pain, that might be very different than the kind of pain that we're talking about here. So it is important to really pay close attention to what you're experiencing. And if you have questions, you're not sure, you just want someone else to clarify, then you schedule an appointment. Vaginal, or you can check out one of these resources. They might help answer your questions, particularly if it takes a long time to get an appointment or you don't have insurance. And then, of course, vaginal discharge. It might be very watery, have a very strong odor, or contains blood. I can't tell you how many times I've had patients that have been experiencing unusual bleeding for short or long periods of time, and they didn't do anything about it. Bleeding is usually, unless it's like a menstrual cycle, or you're known to have you already know you have a particular kind of cancer, or you have something like hemorrhoids. Bleeding is usually not an expected finding, and so you always want to have that addressed. The longer you wait, the more at risk you are for complications associated with what's causing that bleeding, as well as anemia and blood loss. So those are the early symptoms, so pain, bleeding, discharge. And then as the disease gets more advanced, you might also notice that now so remember, when we looked at that picture, this is the front of the female body. So as that mass is taking up space, initially all your symptoms are going to be located in the front of the body. But imagine as it gets larger, now those symptoms are going to start to spread. So you might have more painful or difficult bowel movements. You could be experiencing constipation, and you can actually just have, straight out bleeding. It might be very difficult or painful to urinate, and you also might see blood in your urine. And blood can be so microscopic that even we can't see it until you provide a urine sample. Um, we call that microscopic hematuria. Hematuria is the medical term for blood in the urine. But then it might be blatant. I mean, it might be, no question that that's blood in the urine. Typically, healthy urine is clear and yellow. But if you have conditions like liver disease or kidney problems, some medications can turn it anywhere from orange to brown to like tea color or what we call amber. And then, of course, bleeding is also a possibility. Again, if you have a mass and it's taking up space, so now it's pushing up against other organs, it's pushing up against nerves. Nerves stimulate a sensation. That sensation can be painful. So now you might have a very dull backache. And then, of course, it can go from dull to very strong, sharp pressure. If something's in the way, we've talked about this a few times now. If something blocks circulation, you can have swelling. So if the liquid can't get through, it's just going to build up and accumulate. That can lead to swelling in the legs. So something up here by your waist can have impacts below if that's the direction something wants to travel. Again, it can radiate upward to the abdomen because now we're in this general area. And feeling tired because cancer definitely takes up a lot of energy. Okay, so now we're going to talk about your risk factors for cervical cancer. For most cancers, if you have a family member that has cancer, that increases your risk. So the closer that member is to you, the more likely the higher your risk. So what we call first degree relatives. So that's your parents, your siblings. Those are your first degree relatives. And then you can go to your aunts and uncles, your grandparents. And that's why it's so important for us to share our family history. The history is not just people who are already deceased. The history is right now. If I go and get diagnosed with something, I'm going to tell my brother, particularly if it's going to increase his chance. I'm going to let my cousins know. And, there's definitely a way you can do it that, in our community, there's a lot of concerns always about privacy and people getting, in our business and not wanting their stress. Maybe they manage stress very poorly, and we don't want that energy while we're trying to, just get a diagnosis and take care of ourselves and understand what's going on. So that's something I definitely understand. And so at some point, you just need to figure out how you're going to share it with your family and also ask for your boundaries to be respected. So like anything, if you already have a weakened immune system, particularly if you have cancer or you're on cancer treatments like chemotherapy, if you've had a transplant, and so our immune system is there to fight disease and offending agents, anything that wants to do wrong in our body. So that's bacteria, virus, parasites, fungus, and injuries can also do that. So our body's defense against that is to stimulate an immune response. So that typically sends white blood cells to the area because they fight infection. And it increases fluid to that area because the more blood flow and nutrients and oxygen we can send to that area, the more we can fight whatever is going on. And so so that's usually a desired response. But if we already have an autoimmune disease that's out of control, or we have a transplant that we don't want our body fighting against us, we need to keep this transplant. We need it to keep working. We might take medications that reduce that immune response. So that's where you can see that in our transplant patients in particular. Some of our HIV medications do that. And so if you already have a condition or take medications or undergoing treatment, even in our arthritis patients too, we have some of those, then you're going to be more prone for all kinds of infections and cancer. So cancer and other diseases. So one of the risk factors, the main risk factor for cervical cancer is what we call the human papillomavirus. And everyone who participates in sex, particularly if you have sex with more than one person or they've had sex with more than one person, you will most likely be exposed to that virus. For most people, their body will fight off that virus, but if it's a strong variant of the virus, then it can persist and turn into cancer. So if you have a weakened immune system, you can be at risk for getting this virus, which in turn can lead to cancer. If you smoke, smoking is one of the number one ways to increase your risk for all kinds of cancer, and that includes vaping. I'm going to come back at another time and talk about vaping, what it is, and the risk factors and complications associated with that after having a really enlightening conversation with a young patient this week on what his perception of what vaping can and cannot do. So yes, smoking can increase our risk, and becoming sexually active at a much younger age definitely can increase our risk, particularly before the age of 18, and if we have sex with a lot of people. Other birth control, that there's a particular ingredient in some birth controls that can increase our risk, and of course, the longer we are on it, the earlier we're on it, that can increase our risk. There are a lot of risks associated with birth control, and so we'll have to do a women's health episode coming up. Maybe we'll do that. Yeah, we'll do that. I don't want to. I don't want to say something that we can't actually meet, but we'll put that on our calendar for upcoming special. So even if you don't have sex, but you do have contact with someone else's genitals, that can put you at risk for it, even if you do not engage in sex, however you define sex. But remember, any form of sex, whether it's penetration, external contact, external rubbing through the genitals or the mouth or the anus, so those areas are unique because see the skin, this creates a barrier, and it's protecting everything underneath there. But like wherever you have mucous membrane, so that's like inside your mouth, is easy to see. See how that tissue is much different, right? So if you put something on there immediately, like there's nothing blocking that absorption, it happens immediately. Whereas if I put something on my skin, it actually has to be absorbed. It has to go, so there's some time that involved there. But with the mucous membrane, there's nothing protecting it. The blood vessels are right there. And so once it gets into the blood vessels, it travels your whole body. And so if you're going to have an infection, the best infection is what we call localized, where it stays in one place. Once it hits the bloodstream or the lymphatic system, it can travel throughout the whole body, and that becomes much harder to control. And so those mucous membrane areas put you at risk for all these things. So whether it's oral sex, vaginal sex, rectal, and what makes the vagina different from the penis is externally, the penis doesn't have any mucous membranes until you get right there to the opening. And it's much, much smaller than the opening of the vagina. And so that's why women tend to be at higher risk for certain things like sexually transmitted infections and urinary tract infections because of our anatomy and how quickly something, or the short distance something has to travel to cause an infection or cause a problem. And these were brought to us by the National Cancer Institute, as well as the American College of Obstetricians and Gynecologists. Obstetricians and gynecologists perform these exams. They're very involved in reproductive health, fertility, and pregnancy. So here's our pap smear, the question that inspired this, one topic at a time. So like I said, we're going to have the patient wear a gown, get on the bench, and put their feet in the stirrups. Those are the little placement holders for their feet. And then we're going to ask them to separate their knees. And since I'm on the topic and I don't know when else I would be able to address it, it's better to tell the patient to separate their knees than it is to say spread your legs, particularly for our patients who have had any traumatic encounters. That can be very triggering. And we always want to avoid re-traumatizing people. And so once I learned that, I changed the way I ask people to get into this position, whether it's in the bed or on a bench, is I just ask them to kindly separate their knees. And that works really well no matter the gender or gender identity. So once someone separates their knees, there again, you can see the cervix up there in the little box. And what we're going to do is, so the speculum, as you can see, it's labeled there, is going to be inserted, and that opens it up so we can increases our vision, our visualization of the area. And then we're going to insert that probe and twist it around. And that every time we twist it around, we're collecting cells. Remember, we talked about those cells, that junctional area where typically cervical cancer is found. So we're going to collect those cells, all kinds of cells, as well as the human papillomavirus, detecting to see if it's present. So how often should we do this? That was the original question. So these recommendations were provided to us by the United States Preventative Task Force, and it's always based on the evidence. Is there a lot of evidence that supports that when we do this on a routine or frequent basis, that it actually yields good outcomes in terms of time, money, accurate tests, and patient burden in terms of your cost and time and emotional impact. So the recommendation for screening is doing the pap smear, and doing the pap smear is for women age 21 to 65. So they recommend that you get your cervical cancer screening every 3 years between the ages of 21 and 29. Now that can be younger if you're having sex much younger. So definitely talk to your provider about that. But because sex is what's putting you at risk for getting the human papillomavirus or HPV, then if you're having sex at 13, 16, 18, we don't want you to wait till you're 21, particularly if you're having sex with multiple partners. And if or they're having sex with multiple partners, or they've had sex with multiple partners, or you have HIV, then you would be what we call high risk category. These recommendations here on the screen apply to people who are pretty much low risk. In your 20s, we recommend that you go every 3 years. And then between 30 and 65, you can go every 3 years. And they'll either do the HPV testing alone, or you can go every 5 years and they'll do both the HPV and the pap smear. And again, that's just when they're collecting the cells. But even if you go annually, which insurance typically covers, they still can do other tests, just check for pain, the presence of cysts, talk about any issues you're having during sex or with reproduction or fertility, any kind of pain, if there's any changes in irregularity of your menstrual cycle. So they can perform a breast exam at that time. So even though every 3 years or every 5 years, they might only be collecting cells, the pelvic exam still can yield a lot of really good outcomes when you go have that. So A means that there's a lot of evidence. And so that's why it's in the green. That's why it gets the A rating. The United States Preventative Task Force provides a grade based on the latest evidence. And these recommendations are for primary care. Typically, anyone can provide them. But if you go so they cover primary care. And so they're talking about cancer. But if you go over to the Cancer Institute, or like a foundation that's specific to one disease, they might have different recommendations because that's what they do every single day. And so that's another place you can always look. But these are kind of the general ones across the board that apply for preventative care, primary care. So you can see there's not a lot of evidence to support women younger than 21. And then you have to wonder, well, why is that? Is it because they're less likely to have been having a lot of sex at that point, less likely to be having a lot of sexual partners? And so those would be questions I would have. And so that's why I went into detail a little bit about when we would want to see you younger than 21. But if you don't meet any of those criteria, then more than likely you can wait till you're 21. If you've had a hysterectomy, which is the removal of some of those reproductive organs, it can be a total hysterectomy where they take out everything from the uterus to the cervix, or partial, where they take out certain organs and tissue. And so you'll have to know from your provider what they took out, how much, and if they still think your risk is high, moderate to high, because they still might want you to come back in for that. But technically, if you remove all those organs, your risk can go really low and it might not be necessary. So you really do have to talk to your surgeon and your other provider, to find your OBGYN provider or women's health, to find out how often you should go back. And together you can make that decision. So then for our women who are older than 65, again, this again comes back to whether or not you've had, if you're having a lot of sexual partners, and your risk factors, your familial risk factors, as well as your medical history. So again, you'll have to talk to your provider about that one. But typically what we see is that, as we get older, people tend to not have as many multiple partners or risky sexual behaviors. So that risk goes down. And that's why that rating is a D. But in our upcoming episode for sexually transmitted infections, we do talk about how our retired adults are still at risk for sexually transmitted infections because they're still having sex, they're still dating. So make sure you tune in for that episode. And if I haven't clarified how often you should get your pap smear, just let me know. I can go into it more. So where do these recommendations come from? Again, I think it's important for our community to be transparent about who's making recommendations and where they're getting their evidence from, because you can read the same evidence and that helps inform your decision making with your provider. So as I mentioned, the Preventative Task Force is a group of individuals that includes doctors, some nurses, researchers who have their MD or PhD, or even some people have their MBA. They sit on this task force. They're a voluntary group of individuals, and they look at all the latest evidence, and the ones that have the strongest, most consistent results is where they base the recommendations on. And I'll provide, again, these links in the description box. Right now, here is the board. Here's that task force. As you can see, it's quite a diverse group of individuals. There is a nurse on there at the bottom, and I'll put this link in the description box. But just so that you can see who's making these recommendations, you can see that there's people who look like you, and that's always important that you're being represented when these decisions are being made. So today's, this was one topic at a time. Today, that topic was, how often should I get a pap smear? Well, what is a pap smear? It's screening. It's an exam where we collect cells to screen for all kind of abnormalities, but also cervical cancer, which is primarily caused by the human papillomavirus. And we primarily get that through sex. So I almost forgot. So let's talk about the other aspect of prevention. We have our vaccine. We have our HPV vaccine. So there are a couple organizations that give us recommendations on how often to have you come in and get your vaccines. But the HPV vaccine for adults 19 years and up. So actually, you can get that vaccine as early as 9 years old. And then there's also what we call a catch-up schedule. So if you didn't get it at that age, we can have a different you can still get it. So for anyone 19 years and older, you might get 2 or 3 doses depending on what age you start getting it. Originally, those recommendations were through the age of 26, but some recent research was done that now we've decided that it might be a good idea and that it's safe to continue to make that recommendation up until the age of 45. And I did get mine. I got 3 doses a couple years back. And so that's a schedule that we follow in healthcare, and I think it's great. But this is, text format, narrative format that you might find easier to understand. And so, the recommendation is to start at age 11, but it can start as early as age 9. Depending on what age you get started, it's going to be 2 to 3 doses. So you're going to go the first on day 1, and then you're going to come back within 1 to 2 months for the second one, and then 6 months after that for the next one. If you miss that schedule, we'll let you know when to come back in and how many more you need at that point. This is not recommended for pregnancy, and so you'll have to either wait till you're done or do it in advance. That age 9, as you can see on the screen, is highly recommended for our patients who may have had who either sexually active or have had been sexually abused or assaulted, because again, our risk for HPV or human papillomavirus increases with sexual activity, whether that's consensual or not. And then, of course, our immunocompromised patients, we're going to want to have them vaccinated much sooner as well. And this is provided to us by the Men's Health Network. There is a wonderful chart for both men and women on how often to get screening and testing, and I'll include that in the description box. So we talked about research, and so there was a study that came out. This is a little portion of that study, and it did, and that's where the new recommendation came out, to say that it actually might not be a bad idea, and that it's safe as well to recommend it to adults, men and women, up until the age of 45. So that is all. That was one topic at a time. Today, that topic was pap smear, cervical cancer, and HPV, or the human papillomavirus, and vaccination. Thanks for watching.